Hello and welcome back to Obcast. This is a discussion of point-of-care ultrasound in early pregnancy, and this is a talk that was given at the Fiji 2018 Developing Emergency Medicine Conference. I think the first thing to ask about point-of-care ultrasound in early pregnancy is, why should we do it? Now, this is an ultrasound of a woman with bleeding in early pregnancy. You can see an intrauterine pregnancy there with a heartbeat. This ultrasound is actually from my son, which you can see there on the day we brought him home from hospital, and more recently at Christmas time. We do bedside ultrasound in early pregnancy because it's worth it. The other reason is because there's been plenty of research showing that we're good at it. And so whilst in the emergency department and in other areas of medicine there's many other modalities of point-of-care ultrasound that get a lot of press, I can tell you now bedside ultrasound in early pregnancy can be both diagnostic and therapeutic in what is a really stressful time for young families. I want to talk briefly about transvaginal versus transabdominal imaging. I want to briefly bring up the idea of when a pregnancy should be visible, if it's an intrauterine pregnancy, depending on the type of scan. And I guess the discriminatory zone is a concept whereby a beta HCG of 1500 typically allows an intrauterine pregnancy to be seen transvaginally, and a beta HCG level of 6000 is needed to see or reliably see a pregnancy transabdominally. So I guess there's one difference there. It goes without saying that a transvaginal scan is more invasive for a woman and I guess less commonly done at the bedside. But I guess some other things are that you get excellent images transvaginally versus good images transabdominally. And here's an example. So this is a woman with bleeding in early pregnancy. We can see there she's got what looks to be a gestational sac and maybe a yolk sac in the uterus. But on transvaginal scanning, we can really measure the crown rump length, confirm viability, and see exactly what we're dealing with. A reasonable process by which you decide whether to do a transabdominal or a transvaginal scan, I think, at the bedside is that, first of all, did you get enough information transabdominally? And if you answered your questions, then I think, there's no point proceeding to transvaginal imaging. But I think it's just worth saying that transvaginal scanning is really easy. The probe just ends up closer to the gestational sac and therefore is often a lot easier. And it's a really appropriate and in many centres utilised form of bedside ultrasound. And really just ask the same questions that you would with a transabdominal ultrasound, i.e. is there intra-abdominal free fluid? Is there an intrauterine pregnancy present? And if so, is there a fetal heart rate? So we're going to talk a little bit briefly about how to do transabdominal imaging and then how to do transvaginal imaging in early pregnancy. And I think it's probably first important to say that the women should be lying down, they should be comfortable. The bladder, it can be helpful to be half full just to utilise an acoustic window to look at the uterus. And you can see there a picture demonstrating the probe position with the curvilinear probe and a typical longitudinal view of the female pelvis in early pregnancy. Here's a picture of the pelvis in long section with an intrauterine gestational sac and yolk sac. We usually scan the uterus also in transverse plane, which you can see here on the left, and here's another image of that. In terms of performing transvaginal ultrasound at the bedside, obviously this needs a greater degree of consent and explanation, but then usually the positioning is similar, although a pillow under the buttocks is helpful with the knees bent and apart, similar to if you're doing a speculum examination, and a sheet over the woman's lower half. The bladder should be empty only because this is really uncomfortable with a full bladder, and you should put a condom on the end of the transvaginal probe. Different places insert the probe differently, but I think a well-tolerated method is to have the woman self-insert the probe, and that just allows them to control the insertion in terms of any discomfort, and they can tell you if they'd like to stop. So here's a mannequin showing the transvaginal probe inside the vagina with the probe marker pointing upwards, and that is how we get a longitudinal section of the pelvis, which we can see on the right there. The transvaginal view looks a little bit different. You can see that it's pointing into the anterior fornix here, and we can see the cervical canal and intrauterine gestational sac and the uterus surrounding it. We then rotate the probe with the probe marker orientated to the patient's right, and we're able to fan through a transverse section, and there's an image of that there. Now, I touched on this before, but I think there's 3 basic and very important questions to ask yourself in bedside ultrasound in early pregnancy. And that is 1, is there free fluid? 2, is there an intrauterine pregnancy? And 3, is there fetal cardiac activity? Now, some of you will be able to answer all of these questions and more. Some of you will only be able to answer question 1, and some of you somewhere in the middle. But using this structure, you will always get utility and value out of bedside ultrasound in early pregnancy evaluation. So question 1, is there free fluid? This is a long section of the female pelvis. We can see on the left here some free fluid in the pouch of Douglas, which is behind the uterus here. And on the right hand side we can see free fluid in the hepatorenal recess. Now, in the right clinical context, this would be very suspicious for an ectopic pregnancy. And for those trained in focused abdominal sonography and trauma, or FAST scans, this alone can be very useful at picking out the patients who may need a trip to the operating theatre expedited. I think it's worth briefly talking about vaginal bleeding plus shock in early pregnancy. There is another video on this, but just remembering that if you have early pregnancy bleeding and shock, the differential really is ectopic pregnancy and miscarriage, with miscarriage causing either hypovolemia similarly to ectopic pregnancy or cervical shock. The reason I bring this up is that just the evaluation of abdominal free fluid can really help you decide the ultimate disposition for this patient and the definitive management that's required. So for example here, if we've got a woman with early pregnancy bleeding and shock, if they have free fluid in their pouch of Douglas, or if they've got intra-abdominal free fluid, then they've probably got a ruptured ectopic pregnancy. They need some blood product resuscitation and a trip to the operating theatre for a salpingectomy expedited. Whereas if there's no intra-abdominal free fluid, it's likely due to an incomplete miscarriage causing either exsanguination or cervical shock. So this allows us to prioritise our interventions simply with a scanning modality that we learn and practice on other patients. The next question is there an intrauterine pregnancy? Now, I think the important thing to understand here is that the way in which we rule out an ectopic pregnancy in appropriately selected patients is that we visualise an intrauterine pregnancy. And we know that the specificity or positive predictive value of this in the hands of a non-sonographer at the bedside is very high and very reliable. One of the things that we should say briefly is that a heterotropic pregnancy, being an intrauterine as well as an ectopic pregnancy, occurs in about 1 in 4,000 women, although this rate is much, much higher in those with assisted fertility. So a woman with assisted fertility is not someone you would satisfactorily rule out with just a physician-performed bedside ultrasound. Now, there is some data, though, saying that as a group, doctors are very good at this. There's been a meta-analysis showing that really the sensitivity and specificity, as well as positive and negative likelihood ratios, are really favourable with bedside ultrasound done by physicians in early pregnancy. Alright, I thought we'd talk briefly about what constitutes an intrauterine pregnancy sonographically. Now, the first indicator we get is a gestational sac. It's important to realise that the earliest definitive sign proving that you have an intrauterine pregnancy is the presence of a yolk sac. And then following this, the fetal pole begins just as a thickened part adjacent to the yolk sac and then becomes more recognisable as a fetal pole. And I've got some images to show you here. So here's a transverse section of the uterus with an obvious gestational sac. Now you can see around the periphery of the gestational sac that there is an endometrial reaction, and this here is the yolk sac. The next stage is a yolk sac with a slight thickening on one end of it, which is the earliest part of the fetal pole. And now we have a more obvious crown rump length getting bigger through the subsequent images. I mentioned the third question is there cardiac activity? Now usually you can see a fetal heart by around a crown rump length of 2 millimeters. And it really is the best indicator of fetal viability. It's important we use our M mode to calculate the fetal heart rate, and in first trimester we shouldn't use pulse wave Doppler or colour Doppler. And it's important to understand that the rate of the fetus's heart is much faster than an adult, but that bradycardia portends a reasonably poor prognosis. So we can see on the bottom left here a picture where we have a cardiac flutter in the middle of the fetal pole. Just here. And on the top right hand video we also have a similar cardiac activity with the M mode trace provided below. I thought we'd briefly talk about the criteria for a failed intrauterine pregnancy on ultrasound. I think this is important that we know this. The main parts of the definition are that if we have a mean sac diameter of more than 25 millimeters with no fetal pole, then we have a failed pregnancy. And this is a blighted ovum or an anembryonic pregnancy as it was previously described. The next criteria is that you have a fetal pole of at least 7 millimeters in size with no cardiac activity. Now there are some other criteria below, and really this is for the patients whose mean sac diameter is not yet 25 millimeters or their crown rump length is less than 7 millimeters, and I'll just leave them there to be perused at a later date. Now, all of these criteria have actually been written by the Australasian Society of Ultrasound in Medicine, and they are the standardising body for these kind of decisions. I just thought I'd briefly show some images of an anembryonic pregnancy, unless there's any confusion, and in summary, that is a gestational sac without a fetal pole. And you can see some images here of a gestational sac, and in this case, no yolk sac, although that can commonly be seen, with no fetal pole, and this is consistent with a failed pregnancy. We'll talk briefly about ectopic pregnancy. I think at the bedside it's important to remember that there is not definitive evidence of an intrauterine pregnancy, and in some cases, particularly a ruptured ectopic pregnancy, then can be intra-abdominal free fluid, starting initially in the pouch of Douglas and extending to Morrison's pouch or the hepatorenal recess. Now, of course, there are adnexal masses, vascular patterns to the adnexal masses, visualization of a yolk sac or pregnancy in the adnexum. But what I think is more important to focus on at the bedside is utilizing the free fluid assessment and the lack of intrauterine pregnancy visualized to, I guess, evaluate these women further with formal sonography if there's ongoing suspicion for ectopic pregnancy. It'd be very unlikely to put the ultrasound probe on and pick up a molar pregnancy, and it goes without saying these women need a formal ultrasound and inpatient management. But but it's typically described as a uterus full of grapes, and here's an example picture there now. And the importance is that you see this and you know that this is something I need to refer for inpatient care. Lastly, I thought I'd talk briefly about dating a pregnancy. Now, historically, pregnancies were dated by using the last normal menstrual period. A quick way of working out a due date from there is to add 7 days, take away 3 months, and add 1 year, giving you a rough due date, which is around 280 days after the last period. Increasingly, though, nowadays women are dating their pregnancies with ultrasound. Now, under 12 weeks, the most reliable way of doing that is with a crown rump length. And over 12 weeks, at least in the initial part of the second trimester, biparietal diameter is probably the easiest mode of doing it at the bedside, although there are some more accurate measurements that we would not usually do as bedside practitioners. Now, it's perfectly reasonable to say this is outside your scope of practice, although I think it's actually quite easy to do. And often when women are diagnosed with pregnancy for the first time, they are very interested as to their rough estimate of their due date. There's a study in 2012 showing that we're actually reasonably accurate at doing this in the first trimester, so I don't think there's a reason to be shy on this, although I would just give women a rough or ballpark due date, because families can get very attached to their due date, and realistically these women will be followed up with formal sonography where a more tailored due date is likely to be given to them. But just an additional point on dating, as it's something you may wish to add to your practice. Alright, so that's all I've got to say today on bedside ultrasound or point of care ultrasound in early pregnancy. I hope that's been useful.